Good morning, everybody. Today the topic of discussion is pit and fissure sealant. So, all of us would have heard about this proverb: "Prevention is better than cure." Now, how far this will hold good for our dental field? Now, the goal of dental profession is basically to help the individual to achieve the maximum oral health care throughout their lives. Now, if you see the dental caries, now what is happening in this dental caries? That this dental caries is nothing but an irreversible microbial disease which affects the tooth surface with the help of a suitable substrate as well as cariogenic bacteria, which will finally lead for the occurrence of dental caries. Now, when we know, okay, there are a lot amount of classification or different types of classification of dental caries. Now, if we categorize that classification into the general one, so we can classify that into smooth surface caries, pit and fissure caries, as well as the root caries. Now, when we talk about the smooth surface caries has shown reduction, or the prevalence of the smooth surface caries is reduced from past 2 decades. Now, there are various factors which have been put forwarded for this reduction of dental caries, that is especially the smooth surface caries. So those factors are the use of dentifrices or the changes in the diet, improved oral hygiene by the person, as well as water fluoridation. And moreover, with all these factors, the awareness by the patient himself has helped to reduce the smooth surface caries. But the caries still occurs in childhood and adolescence. Now, what is this caries which still occurs in childhood and adolescence? It is the pit and fissure caries. Okay, now we know that there are a lot of factors or agents which we use to reduce this the caries occurrence, like the preventive agents. So one of the most important agent what we discussed before, like, is the use of fluoride. Now, does this fluoride does not help to reduce this pit and fissure caries or smooth surface caries? Now, to understand that, if there is a systemic ingestion of fluoride, okay, it reduces the smooth surface caries when compared to pit and fissure surfaces. So, even with optimal fluoride therapy, when we talk about the optimal fluoride therapy, okay, the topical application or anything, so the pit and fissure caries can be delayed, but it can't be prevented. Okay, we can delay the occurrence of the pit and fissure caries, but it can't be prevented completely. So, to reduce the occurrence of the pit and fissure caries, what we say is the occlusal sealants can be introduced into any kind of caries preventive program. So, we say that it is an adjunct in any caries control program, the use of occlusal sealants. So, these occlusal sealants can be used in those areas which are caries susceptible as well as which are least benefited by the fluoride therapy. So in those areas where fluoride is least benefited, okay, we can use this occlusal sealants. Now these occlusal sealants, when we use it on the pits and fissures, it acts against all the three basic factors which leads for the occurrence of the dental caries. Now what are those three factors? The three factors are: it acts by physical obstruction. When we place an occlusal sealant, it acts as it physically obstruct any kind of debris entering into the fissures. The next is prevents colonization of pits and fissures with the new bacteria. So there is no approach of the new bacteria to the deep part of the pits and fissures because it is obstructed. Now prevents entry of fermentable carbohydrates. Because of the obstruction, the fermentable carbohydrates can't be accessed to the depth of the fissures. So keeping all these three factors, the remaining bacteria cannot produce acid in the cariogenic concentration, basically protecting the tooth against the dental caries. So we will discuss more in detail about the pit and fissure sealants. So in this class, we'll be discussing about what are pits and fissures, why they are caries susceptible, what are the types of pits and fissures, what are the classification of pit and fissure sealants, where we can use this and where we can't use this pit and fissure sealants, what is the detailed procedure in application of the sealant, and how do we maintain the sealant. So these are some of the topics which we'll be discussing in this class. Now, what are basically pits and fissures? Now, if you see the photo, the pit is defined as a small pinpoint depression located at the junction of the developmental grooves or at the terminal of those grooves. These are pits. Now, what do you mean by fissure? Now, fissure is defined as a deep cleft which is between the adjoining cusps. So, these are the basic definition of pit fissures. Now, why these fissures are caries susceptible? Now, if you see the photo, what is happening? In the second picture, the bristles will not be effective in cleaning the deepest part of the fissures. So, because if any food debris gets accumulated in the deepest part of the fissures, okay, so they are least accessible or least cleansable by the toothbrushes or any kind of oral irrigation devices. So, because of which they are more prone for caries. Moreover, these fissures are enamel faults. They are narrow shafts or cracks, and these ends are more or less towards the dentin enamel junction. Now, because they are able to cleanse at the deepest part of the fissures, and the ends are directed towards the dentin enamel junction, the progression of the caries will be faster. Okay, so they are these fissures are caries susceptible. Now, when we talk about the types of fissures, these fissures extend from enamel towards dentin enamel junction in different shapes. Now, what are those shapes? Now, based upon Nagano, he identified 5 types of fissures. They are I, K, U, V, and inverted Y types. So, there are basically 5 types of fissures: U, V, I, K, and inverted Y types. Now, when we talk about the U and V shape, what they say is they are shallow, they are wide, self-cleansable, and they are caries resistant. Now, why they are caries resistant? Okay, anything at the depth of this U or the V-shaped fissures, if any food debris is accumulated, they can be easily cleansed by a simple irrigation or gargling of the mouth, or it can be removed by the help of the fissure, the toothbrushes. The bristles can easily approach the depth of the fissures. So they are self-cleansable and they are caries resistant. So the caries resistant pits and fissures are U and V shaped. Now going to the remaining fissures, that is I, IK and inverted phi fissures. Now these fissures are called as caries susceptible pits and fissures. So I, IK and inverted phi fissures are caries susceptible pits and fissures. Why they are caries susceptible? Now if you see the I shape, what is happening? There is a narrow and it is very deep. If you see from the starting to the bottom, it is narrow and very deep. Now anything accumulated at the depth of the fissure can be cleansed by the bristles or by oral irrigation. Now the same way IK and inverted Y. Now what is happening in this type of fissures are they are narrow slit like opening. If you see the opening, it is narrow and it is narrow opening, and if you see the base is very large, okay, and the ends are directed towards the dentin enamel junction. The distance between the base of these fissures and the dentin enamel junction is very less. So these are caries susceptible pits and fissures I, IK and inverted Y. Now what are basically pit and fissure sealants? If you go with the definition of these pit and fissure sealants, so it is used to describe a material that is introduced into the occlusal pits and fissures of a caries susceptible teeth. Now when they are introduced into the occlusal pits and fissures of a caries susceptible teeth, what they do? They form a micromechanical bond as well as a protective layer. So once a micromechanical bond is formed, and a protective layer is formed, they cut the access to the caries producing bacteria from their source of nutrients. So basically, they act as a physical obstruction from the external environment. Now come to the classification of pits and fissure sealants. Now, according to Mitchell and Gordon in 1990, it has been classified into three types based upon generation, based upon the filler content, and based upon the color. Now coming to the base like on the generation, they are classified into four subtypes. That is first generation, second generation, third, as well as fourth generation. When we come to first generation of pit and fissure sealants, now if you see them, they are cured by UV light at a wavelength of 356 nanometers. Okay, now what is the disadvantage of this system? Okay, the disadvantage of this system is there's an incomplete polymerization of sealant at the depth. Okay, when you place this first generation pit and fissure sealant in the pits and fissures and you cure them, the depth of the fissure is not cured. Now, when they are not cured, they does not form micromechanical bond at all. Now, what happens? The retention of the sealant is very less in this first generation. Now, so they came up with a second generation sealants. Now, what are these second generation sealants? They are self-cure resins. Now, what are they? They are based upon the catalyst accelerator system. The hardening of the cement happens through catalyst accelerator system. Okay. Now, most of these second generation sealants are unfilled resins. They may be transparent, they may be tinted, or we may call it as opaque. Okay. So they are clear or tinted or opaque in color. Now going to the next generation of sealants, that is the third generation or the light cure sealants. They are cured by visible light at wavelength of 430 to 490 nanometers. Now these sealants are filled as well as unfilled. Okay, they appear as with or without tint or opaque, means they say that it is available in the form of clear, tinted or opaque. Most of these unfilled resins are colored white. Okay, whereas the filled resins are either clear or we can call them as transparent or yellowish white or tan in color, means we say it as opaque. Now the fourth generation, the advantage of this fourth generation is they release fluorides. Okay, now they are fluoride releasing sealants. These are some of the trade names, that is Helioseal, Delton, Ultra, X-Seal and Fluoroshield. They are some of the names for this fourth generation sealants. Okay, in the dentistry, in the present generation, we are using the third generation or fourth generation sealants. Now coming based upon the filler content, okay, so they can be classified into unfilled or filled. Now what is the advantage between unfilled and filled? The unfilled resins, in the unfilled resins, the flow is better when compared to the filled resins. The retention is more in case of unfilled and abrade faster. Whereas when we talk about the filled, they require occlusal adjustment. They does not abrade faster. They are more resistant to wear. Okay, so the unfilled, you should know if you are using an unfilled resin, so the retention is more, abrades faster, the flow is good. Now come to the filled ones, you need to reduce the high points, that is need for occlusal adjustment, and they are more resistant to wear. Okay, now moving to the next one, that is based upon the color. You have clear, tinted, opaque and pink. Now come to the clear part. What is the advantage of this? Now if you see the picture, it is aesthetic in nature. Difficult to detect at recall examination. When the patient comes to you after 2 months or 3 months for regular checkup, it is difficult to detect in the clinical examination. More appreciated by the patient because it is aesthetic in nature. To come to the tinted, it can be easily identified because we can see it very clearly. So it is easy to see during placement as well as easy to see during recall checkup. The opaque also, same features what we can use it for tinted. It can be easily identified when the patient comes to you at recall visits. Now the pink one, we call it as better fluoride release. Now there is one more thing what we call it as color changing technology. Now the color of the sealant here is pink, and when you cure them, it turns to white. Okay. Now, the advantage of this color changing technology is until the complete polymerization does not take place, it does not change to white in color. So it's an additional advantage that you can clearly affirm that the sealant has been cured completely. Now coming to the indications of pit and fissure sealants, it can be used in deep retentive pits and fissures as well as stained pit and fissures with numerous appearance of decalcification. Other than that, it can be used in patients with high risk of caries, patients undergoing orthodontic therapy, or patients suffering from xerostomia, or children and young people with medical, physical, or intellectual impairment. We can call these children as special children. Now, why we need to use them? Because because of the impairment or because of the condition what the child is having. Okay, so it may be difficult for them to maintain the oral hygiene very effectively. So to reduce the occurrence of caries, we can seal the pits and fissures in these patients, okay, so that it will be beneficial for them. The last thing is no radiographical or clinical evidence of proximal caries. So these are some of the indications for pit and fissure sealants. Now coming to the contraindications, well coalesced self-cleansing pits and fissures means according to the Nagano, what are those? They are U and V shaped. Whereas for the indications, we can use the I, IK and inverted Y. Well coalesced self-cleansing pits and fissures are only U and V. The radiographic or clinical evidence of interproximal caries. If you see this, no placement of pit and fissure sealants. If the tooth is partially erupted, the disadvantage in this condition is we are not able to maintain the isolation part, which is the most crucial step in pit and fissure placement. So that is one of the things why we can't place it in case of partially erupted teeth. Life expectancy of the tooth is limited. Means if you are placing on a tooth which is very near to the exfoliation, for example, the deciduous tooth, so we need to think about the age of the patient and what is the exfoliation of that tooth. It is very close to it, then don't place the sealant on it. The last is lack of preventive practices. If you place pit and fissure sealant in these patients where they lack preventive practices, then there is no point in placing pit and fissure sealants. Okay, so you are avoiding something, but the patient is coming with other issues. Now, the selection criteria for sealant, that is sealant application or the selection of patient. Now, based upon the age, okay, it is 3 to 4 years, 6 to 7 years, or 11 to 13 years. Now, 3 to 4 years basically because the primary molars would have completely erupted. 6 to 7 years because the permanent molars would have erupted. 11 to 13 years basically because the second permanent molars as well as the bicuspids would have erupted. The next is based upon the clinical judgment. Now, the first part is the age. Now, keep the age under consideration. Next is the oral hygiene. If the patient is maintaining the oral hygiene practices very correctly or not. Now, if there is a familial or individual history of dental caries, that is if the patient is under high risk category also. If the dietary habits are not good, tooth type and morphology. Now, depending upon the different types of tooth morphology, we decide whether to place them or not. So basically, in kind of amelogenesis imperfecta or dentinogenesis imperfecta, we don't go with the placement of pit and fissure sealant. So you need to understand the tooth type and morphology, and based upon that, we can decide whether to place sealant or not. So keep in mind, based upon the age, we can decide the selection of patient or based upon the clinical judgment. Now, which teeth should be sealed? Now, in children and adolescents, we should seal the first and second permanent molar teeth as well as the bicuspids. The second is routine application of sealants on primary molar teeth, which is usually not recommended, but we may consider placement of pit and fissure sealants in primary teeth if the patient is under high risk category. Now, how should teeth be assessed for sealants? Now, how should we diagnose that this teeth should be placed pit and fissure sealants? Okay, there are a lot of advancements in the diagnosis. Now, the radiographs and other diagnostic procedures, technologies are not indicated only for the sole purpose for placing pit and fissure sealants. It can be used for other. At that time, we can adjunctively diagnose these pit and fissures. But specially to identify the pits and fissures, the radiographs or other diagnostic techniques should not be implicated. The probe should not be used to explore pits or fissures because it may damage the tooth surfaces when we probe the deep pits and fissures. Now, so what we should do? We should clean, dry, and well illuminate for visual assessment for the to diagnose the teeth for deep pits and fissures and to seal those pits and fissures. When this sealant should be applied? The sealant should be applied as soon as the tooth is sufficiently erupted and we can isolate it completely. So understand, so if the tooth is sufficiently erupted and we can isolate very effectively, you can go with the pit and fissure sealant. Now coming to the application, sealant application. Okay, these are some of the armamentarium which are used for the placement of the sealant. Okay, so you need to arrange all these armamentarium before you place the pit and fissure sealants. Okay, before we go for the procedure, we need to make the patient in a specific position. Now, it is indicated is for maxillary teeth, you place the patient in supine position, and for mandibular teeth, place the patient in semi-supine position. Now, why? Why is this concept supine and semi-supine position? Now, depending upon the angulation of the tooth or the angulation of the occlusal plane. Okay, for maxillary teeth, place a patient in supine position. You apply the pit and fissure sealant at the mesial end, and it, because of the plane, it slowly moves to the distal end. It's the same way for the mandibular teeth in semi-supine position. If you place the pit and fissure sealant at the distal end, it slowly moves to the mesial end. So the patient position is one of the most important factor when you are placing the pit and fissure sealant. Now, before we go with the placement of sealants, once you have place the patient in a proper position, you do mechanical cleaning of the tooth. Now, the mechanical cleaning is nothing but as oral prophylaxis. Why we need to do this? We need to remove plaque and debris from the enamel and pits and fissures of the tooth. So, once you remove all this plaque and debris which are accumulated, then you can polish it by using pumice and water mixture using a rotary brush. Okay, now when you are using this pumice and water mixture using a rotary brush, you will always, with the advantage, like what is the advantage? You will always remove the debris as well as plaque from the surface of the tooth or the pits and fissures. Okay, how much ever is possible. The next is isolation of the tooth. Now, the isolation step is one of the most critical step during placement. If this is achieved, your sealant retention is very good. So it can be done by placing a rubber dam or cotton rolls, or you can use the absorbent pads. Now, during the placement of sealants, you can use a saliva ejector and dry the tooth surface with compressed air. Now, if you do this, because the isolation is one of the critical stage in the sealant application. Now, the major step comes is the etching of the tooth surface. Now, you need to etch the tooth surface to be sealed. Now, what is the acid which is required for the etching of the tooth surface? Now, what we say is 37 phosphoric acid is used for etching the tooth surface. Now, we need to apply over 2 to 3 mm of cuspal inclines. Now, why we need to apply 2 to 3 mm on the cuspal inclines? Basically, it is required because we need to seal the supplemental fissures which are present on the cuspal inclines. So these supplemental fissures are usually present in the 2 to 3 mm on the cuspal incline. So you need to etch the main pits and fissure as well as 2 to 3 mm of the cuspal inclines. Now, once you etch the tooth, okay, now if there is a salivary precipitation or salivary contamination, what exactly happens? So the salivary precipitation of glycoproteins onto the edge surface decreases the bond strength of the sealant. If there is a salivary contamination, it decreases the bond strength of the material. What we say is, if there is an like 1 second exposure of saliva on the tooth surface after etching, what will happen? It forms a protein layer. It forms a protein layer which is resistant to 30 seconds of vigorous irrigation. Now we are saying, if there is an 1 second exposure of the saliva, we require what amount is required? We require 30 seconds of vigorous irrigation to remove the protein layer which is deposited on the tooth surface. So if it is more amount of exposure, then the more amount of time with vigorous irrigation is required to remove the protein layer. Okay, so after etching the tooth, the isolation is most important. Okay, we will discuss some few issues the characteristics of etched enamel. Now, we all know that the normal enamel is composed of hydroxyapatite crystal. True? So we all know this. Okay, if you see the normal enamel, now what is the properties of this normal enamel? Now this normal enamel is a low energy, a weakly reactive, and hydrophobic state. Now what do you mean by hydrophobic? It does not absorb the water. The hydrophobic means the water does not stay on the surface. It repels the water. Okay, it moves the water away. So the enamel is a low energy, weakly reactive and hydrophobic state, the normal enamel. Now, when we expose this normal enamel to the acid, now what is going to happen? Now, all the properties of the normal enamel gets changed. Now, what will happen? So, the low energy becomes high energy, the weakly reactive becomes strongly reactive, and hydrophobic state becomes hydrophilic state. Now, what is the advantage of this hydrophilic state? Now, this hydrophilic surface provides rapid attraction of the sealant onto the enamel surface. So that is the advantage of etching also. Okay. Now, the other advantage of etching is it increases the surface area as well as the porosity of the surface. Now, this increased surface area and porosity of the surface is basically due to the result of selective demineralization of the hexagonal prisms. Now, how this happens? Okay, when the selective diminution of the hexagonal prisms happens, the three surface patterns are observed. Now, what are these surface patterns? Now, if you see the hexagonal prisms in the picture, now the center part is called as prism core. The borders are called as prism periphery. Now, the three surface patterns are formed by preferential removal of the prism core or preferential removal of the prism periphery, or there may be a combination of both. Now, based upon this, there is a selective demineralization on the hexagonal prisms. Now, if you see the histological picture of a fetus, the etched surface has three zones. Now, what are those three zones? Okay, the first zone is called as etched zone. The second zone is called as qualitative porous zone. The third layer is called as quantitative porous zone. Now the etched zone is of 10 microns in depth. The qualitative as well as the quantitative porous zone are 20 microns in depth. So overall it is 50 microns of depth is established. So 20 plus 20 plus 10. A total of 50 microns of depth is established. Now if you see the picture, the first layer is the etched zone, the second is the qualitative, and the third is the quantitative. Now, if you see the second picture, that is the dark shaded one, okay, the projections we call them as resin tags. Now, what are these resin tags? Now, once you etch the tooth surface and they are formed, and you place the sealant, so the sealant enters into this porous zone and forms a resin tags. Now, these resin tags are responsible for the mechanical retention of the sealant. Now, this resin tags is nearly around 40 millimicrons in depth. Now the other 10 microns is the edge zone. So the resin tags, if you see the resin tags are 40 microns in deep. Now come to the time duration for etching. So if you see the etching pattern, etching time, it is more for primary and less for permanent. Okay. Now we are saying it is more for primary and less for permanent. The wash and dry is the same for both primary and the permanent tooth. Now, why we need to etch the primary tooth for a longer duration? Why it requires more? Okay, if you see in primary teeth, why we etch more? It is basically because there is a prismless enamel. When you talk about the enamel rod formation, okay, so this lack of enamel rod formation during the last 25 microns of enamel on the tooth surface. So in this area, the last 25 microns, so no prisms are formed. So this is because there is a reduced functional activity during the terminal stages or the last stages of amelogenesis, which results in lack of enamel rod formation at the last 25 microns of the tip. So there are no prisms formed. So there is prismless enamel. Now, if you etch for a shorter duration, what is going to happen? You're creating just a micro porosities rather than surface patterns. But for the mechanical retention of the sealant, you need to have the surface patterns. The resin tag should be formed. If there is a micro porosities only, the resin tags are not formed at all. So you need to etch for longer duration to obtain these surface patterns on primary tooth. The second reason is there is more organic content in primary enamel, which is very difficult to etch. So that is the one reason why this primary teeth requires more etching. So the prismless enamel and more organic content in primary enamel is the basic reason why we need to etch for longer duration in case of primary tooth. Now, once you do all this etching and everything, what we need to keep in mind? We need to rinse and dry the etched tooth surface. Now, what we are going to do when we rinse the ear? It removes the etching agent from the tooth surface. It removes the reactionary products which are formed after the etching. Now, what we need to do once you do remove all these things, we need to dry the tooth for 15 seconds. Now, once you dry the tooth for 15 seconds, what we are going to observe? We are going to observe a dried surface, or we call it as frosted white appearance of the tooth. Now, this clearly indicates that the tooth has been etched. If you observe a frosted white appearance, it means that the tooth is clearly etched. Now, if salivary contamination has occurred after the etching, okay, you remember that what we said, 1 second of exposure of saliva onto the edge surface, it causes, okay, a protein layer which is resistant to 30 seconds. To remove that protein layer, we need to do a vigorous irrigation for a period of 30 seconds. So if there is a salivary contamination, what we need to do? We need to re-etch the tooth for 10 seconds more. Okay. The normal etching time also, with that, if there is a contamination, we need to etch for 10 seconds more. Usually we should not do this. We need to maintain a proper isolation so that it should not happen. Now, once it is maintained, you apply the resin onto the pits and fissures. Okay, depending upon the position, either you can place it on the mesial end or the distal end. Okay, the tooth, whatever the tooth you have planned to place it, make the patient in that position, and you can go with the sealant placement. So once you apply the sealant, cure it. Okay, now once you cure, you need to evaluate the sealant and adjustment of occlusion. Now, once you place the sealant and cure everything, take a probe and just probe along the pits and fissures. Now, if the sealant has completely flowed onto all the pits and fissures, there will be no catch. Now, if there is a catch after you place the pit and fissure sealant, means you have left out some amount of pits and fissures. So, you need to seal them back. Okay, the second is adjustment of occlusion. Now, if you are using a filled resins, you need to adjust the occlusion. If you are using an unfilled resin, there is no need to adjust the occlusion because they abrade faster. Okay, unfilled resins, no need to do the occlusal adjustment, they abrade faster. But whereas in case of filled resins, you need to do occlusal adjustment. Okay. Now these are the pre-operative and the post-operative. Okay, the pre-operative we can clearly see the decalcified as well as stained pits and fissures. Now the post-operative, here the sealant type is the clear sealant type or transparent sealant type. Okay, so it is aesthetic in nature as well as when the patient, the only disadvantage is when the patient comes to us, it is difficult for us to evaluate at recall visits. Now, if it is opaque, it has its own advantages. The clear, it has its own advantages. Okay, now what are the common problems what we face? Improperly etched surface means the tooth does not appear dry as well as frosted white appearance is not seen. The contamination of application site means once you etch the tooth surface, there is a contamination of the saliva to the surface or any moisture contamination. Non-adherence of sealant material. Okay, we have etched, we have placed the material, but as soon as we dry, the material comes out from the tooth surface. It also, these all things says that you need to re-etch the tooth for more time. Re-etch the tooth for a more time as well as properly, keeping all the other instructions in mind. Okay. Now coming to the failure of sealants. If you see the failure of sealants, the moisture contamination is one of the most reason why we see a failure of sealants. Early loss means less retention of the resin. The partially erupted tooth, if you place sealant on a partially erupted tooth, the salivary contamination, you are not able to isolate it properly, so there may be a failure of the sealants. Occlusal parafunctional habits. Now what is going to happen, like bruxism or any other parafunctional habits? Okay, so when you place a sealant and there's a continuous grinding of the tooth surface, the retention is compromised. The sealant will be lost very early. Patient behavior problems. If the patient has issues with this behavior. Now, if you see the wear of the sealant in occlusal parafunctional habits, because of the continuous grinding of the tooth surface, the sealant, what is going to happen? It slowly starts abrading. Okay, as well as the retention is also lost. Now coming to the other part, the age of the patient. Very young patients, okay, wherein it is very difficult to treat them or difficult to have a proper isolation, or if the patient behavioral issues are there. All these things lead for failure of the sealants. The final thing is the enamel structural defects such as amelogenesis imperfecta and dentinogenesis imperfecta. Because of the tooth morphology or the tooth condition or these teeth, we have difficulty during etching. Okay, the porous zone, all these things, the surface patterns are all compromised. So in these defects, so if you place sealants, then we may face the failure of the sealant because they easily chip off. Already the tooth is weakened. Once you etch the tooth surface, you are still weakening the tooth surface, which leads for the failure of the sealant application. Now, when we should follow? Now, what they say is the recall interval for high caries risk children should not exceed 12 months. It should not exceed 12 months. You should recall them early. If there is particular concern about sealant retention, recall within 6 months is appropriate. If you feel that retention may not, the retention of the sealant is compromised, then you need to recall them before 6 months. So in an average, what we say is an average of like the patient should be recalled every 6 months once you have placed sealant on the tooth surface for proper evaluation. Now come to the repair of the sealants. Okay, now there are two conditions. If the sealant is completely lost, you need to reapply the sealant. Okay, if there is a partial loss of the sealant, means a part of the sealant is lost. Now what we need to do? we need to roughen with a diamond stone the remaining area, re-etch for 20 seconds, and reapply the sealant. Okay, so this we can do it if there is a partial loss, a part of the sealant has been lost. Okay, we can do this procedure. So keep in mind, if it is totally lost, reapply the entire sealant. If it is partial loss, you roughen with diamond stone, re-etch for 20 seconds and apply the sealant. Okay. The next is use of bonding agents. So overall in the procedure, we said that bonding agent, we never mentioned about bonding agent after etching the tooth surface. Okay, now, uh, is it applying bonding agent, will it really help us? Okay, now what the studies have shown is the use of a dentin bonding agent increases the sealant retention in teeth when salivary contamination has occurred. So if you go back to the indications, what we say that if you are not able to isolate properly, if there is a salivary contamination, in those conditions, if a salivary contamination happens by chance, to increase the sealant retention, what they advocate is use dentin bonding agent also. But the use of dentin bonding agent is definitely recommended in clinical situations where strict isolation is not at all possible. For example, a newly erupted teeth should, if you want to seal it, and when patient cooperation is not at all ideal and you need to place pit and fissure sealants, you apply the dentin bonding agent onto the tooth surface and go with the application of the pit and fissure sealant. Okay, so if you have any doubts with pertaining to this, you can meet me in the office. And there is one more thing, like you need to concentrate onto the definition, the classification, the procedures, the surface patterns, why enamel, why dentin, why we need to etch for more time. Okay, what are the surface patterns, what are the histological zones. Okay, finally, I want to remind you that, okay, the total depth is 50 microns in micrometers, but if we talk about only the resin tax, it is 40 microns in depth. Only the resin tax. The overall depth is 50, but only the resin tax formation, it is for 40 using the qualitative as well as the quantitative porous. Okay. So other than this, there is something called as preventive resin restorations. Now, what is it basically? These are is they are divided into three types: type A, type B, and type C. Now, for example, in the center, there is an occlusal pit in the central part of the tooth. Okay, if the central, the caries is limited only to the enamel, what we do is we slightly widen the pits and fissures, we remove the caries, okay, and then we place an a flowable composite or a resin onto that and cure it. This is under type A. Now type B is if the caries is extending little to the little part of the dentin. So now what we do here is, okay, we remove the caries everything in the caries area, then place a layer on, place the GIC cement. Over that, you etch the tooth surface completely, the remaining sound pits and fissures, and place pit and fissure sealant onto the GIC material, including the remaining sound pits and fissures. The next part is type C pit and preventive resin restoration. Here, what we say is it is a deep carious lesion only in the central part or any other area. But there are other sound pits and fissures which are not affected by caries. Now, in that area is you remove all the caries which is very deep. Then you place a layer of calcium hydroxide for formation of reparative dentin. Then place a layer of GIC. And then go with your composite restoration or glass enamel restorations completely as the composite or glass enamel, and etch the tooth surface again. Then place the pit and fissure sealant over the restoration as well as the remaining sound pit and fissures. So this is called as preventive resin restoration. So we can apply this pit and fissure sealants as well as the preventive resin restoration during the clinical practice, because you would have restored the tooth which is affected by caries, but there are other areas which are affected by, which are not affected by caries. That is the sound pits and fissures. So after you do the restoration, you need to seal the remaining sound pits and fissures for the prevention of the occurrence of caries in these fissures. Okay, so thank you so much. If any doubts are there, you can please contact me either through you can WhatsApp me or you can meet me in the office. Okay, thank you so much.